Hi, my name is Dharam Kumbhani. I'm an interventional cardiologist at UT Southwestern in Dallas, and I'm really pleased to be here to discuss the result of the DAPT-MVD trial, which was presented this morning by Dr. Fang on behalf of her colleagues. So this was a very large and interesting study that was done out of 97 centers in China. The patients that were enrolled in this study were patients who had had prior drug-eluting stent implantation and had successfully completed 1 year of dual antiplatelet therapy with either aspirin and clopidogrel or aspirin and ticagrelor. And then at the end of this 12-month, if they had had no ischemic events and no bleeding events, then they were randomized to either continuing DAPT for another 12 months or then transitioning to aspirin monotherapy. So the investigators assessed about 9,000 plus patients for eligibility and ended up excluding 6.4 patients. So finally, they enrolled 8,250 patients who were equally randomized to one of these two strategies. Now, dual antiplatelet therapy was with aspirin and clopidogrel, and as I mentioned, the other arm was aspirin monotherapy. So these patients were followed for 36 months. And what they noted is by around 12 months or so, there was a separation in the primary endpoint of MACE events. This was statistically significant at the end of follow-up, about an 18% reduction in MACE events in favor of dual antiplatelet therapy. Importantly, there were reductions. This was primarily driven by reductions in myocardial infarction. Stent thrombosis rates were very low. In the entire population, there were only 2 stent thrombosis events. Now, what was really equally important is they achieved this reduction in ischemic events without seeing an increase in bleeding events. So the primary safety endpoint, which was BARC 2 to 5 bleeding, was about 1.5% and equal in both arms. So when they also did the subgroup analysis, they found that the results were fairly robust across multiple subgroups that they tested, with perhaps a signal for higher bleeding or lower benefit in patients with a higher BMI. So what they took away from this trial was that extending the duration of dual antiplatelet therapy among patients who had completed a year of DAPT 1 year after PCI was beneficial in reducing ischemic events without increasing bleeding events. So this is a very important study, and we saw the DAPT trial that was conducted nearly 2 decades ago, where we saw extending DAPT beyond 1 year was beneficial in reducing ischemic events. But interestingly, in the DAPT trial, there was an increase in bleeding events. So you kind of balanced out the ischemic events by also increasing your bleeding events. Now, the field has swung significantly since the initial DAPT trial, and we were trying very hard to reduce stent thrombosis events at that time. In the current trial, as you saw, there was a significant reduction in events primarily driven by a reduction in MI, but not necessarily stent thrombosis. In fact, stent thrombosis was very rare. So, I think it also speaks to how far the field has come as far as, the use of conventional stents, the use of intravascular imaging, where I think the majority of the benefit that we are potentially seeing from extending dual antiplatelet therapy beyond 12 months is going to be driven by a reduction in MI. So it speaks to the burden of ischemic disease. And indeed, they also tried to select a population that had a high ischemic burden. So these were patients with multi-vessel disease. And in fact, when the DAPT trial was presented, they published a DAPT score, which has been, very, very helpful for clinical care. And if you look and plug in some of the components of, the patients that they enrolled, they probably enrolled a fairly high DAPT score population. And I think what they were able to do is simultaneously recruit a group of patients that had also a low bleeding risk. So although they don't provide, the baseline bleeding risk based on, a variety of scores that are available, they do show that the bleeding risk in this population is very low. So I want to also mention, how things have changed since the initial DAPT score. So we have seen how trials have now suggested that it is possible to curtail the duration of antiplatelet therapy in most patients, perhaps not including STEMI patients. And this is possible if instead of de-escalating to aspirin monotherapy, the de-escalation is to P2Y12 monotherapy, whether that is clopidogrel, which we have seen in multiple trials, or ticagrelor, for example, what we've seen in the Twilight study. So I think, and the guidelines also now reflect this, where a shorter duration of DAPT is feasible. So I think one aspect that this study does not answer is at the 12-month mark, when the randomization was to dual antiplatelet therapy versus aspirin monotherapy, would the results have been potentially different if the de-escalation was to clopidogrel monotherapy? So I think that remains an unanswered question, but be that as may, I think this is an important study. I think this will be an important tool in the armamentarium for physicians when they try to make personalized decision making for their patients. If the ischemic risk is felt to be high, and if the bleeding risk is felt to be low, then certainly this is a population in which one might consider potentially using an extended duration of DAPT for another 12 months based on this study. So one last caveat I'll say is that this trial was done exclusively in China. And so, the BMI in those patients is typically lower than what we see in the Western world, especially in the United States. And so given that there was maybe a signal that things may look different in higher BMI, I do think this is a result that probably warrants, validation in other populations. So that's all I have on this study. Thank you so much for your attention, and hopefully you find this summary helpful.